Good morning, good afternoon, and good evening to all speakers, chair, and moderate commentators, and of course, our audiences. Today is our 12th ACNN webinar. Thank you for being here. And without delaying, shall I call upon Professor Yoko Kato to give us the opening speech, please, Prof.
Yes, thank you very much, E. So another nurse webinar, I think that the nurse role is very, very important, and they need more skills and knowledge in the future. Then we work together. So the purpose, I think this webinar is very, very important. Today we have 3 good speakers, very exciting to hear their report. And also, as a commentator, Lene is a great female neurosurgeon now. And also, I'm happy to receive the Byron. Thank you very much for your joining us. So, shall we start? So, please unmute.
Okay. I just want to do a brief introduction. Okay, today we have Prof. Arunkumar Sekar, who is Associate Professor, Department of Neurosurgery from AIIMS Ubaniswa, and his topic will be spinal cord injury. And the nurse speakers will be Ms. Grace Kombe from Tanzania. She's going to talk on spinal cord injury nursing perspective. Ms.Irene will be talking on a case report about spinal cord injury, and also from Tanzania. Both nurses are doing fellowship now in Fujita. And the next 2 will be Mai Ukombo and Nana, both from Japan. They are going to share a short report on the 22nd annual meeting of Vietnam Neurosurgical Society, which they attended in December last year. So our session chairs will be Prof. Chandan Prasad, an associate professor from Kaliga Institute of Nursing Science, Kaliga Institute of Industrial Technology, deemed to be University Institute of MNIS, Bhubaneswar, India. And for the nursing session will be chaired by Ms. Savia Masavi. She's a credentials registered nurse, CCN nurse. Of course, now she is a neurosurgical nursing training coordinator in Muhyiddin Orthopedic and Neurosurgery Institute, Tanzania. And our commentators will be Professor Lynn Alusina. She's the chair of Neurotrauma AASNS, Vice President of AFNI, past President of University of the Philippines, Faculty and Alumni of the Neuroscience, Nominating Committee of WFNS, and Chair of BRHMC. And of course, Prof. Ryan is the another commentator. He is the past President of SENC and Secretary of FLANC. I think without further delay, may I call upon the first chair, Prof. Chandan, to chair Professor Arunkumar's session. Please, the floor is yours.
Yeah, very good evening to one and all. Am I audible?
Yes,
Yeah.
yes, you are.
Yeah. So thank you very much for having me here. It's a great opportunity to have. The world is very small, and thanks to COVID, we have learned this new ways to get connected to each other for greater learning. So I welcome the first speaker. Uh, so let me introduce the speaker before we can have the first session. So we have with us Dr. Arun Sekar. He is an associate professor from All India Institute of Medical Sciences, Bhubaneswar, and he has done in MBBS in 2007 from the Pondicherry Institute of Medical Sciences, and done his MCH in neurosurgery from NIMANS, a very important and prominent institute in all of India related to neurosciences and mental health, and then has done his DNB in neurosurgery from the National Board of Examination, New Delhi. So I welcome Dr. Shekhar so that he can continue the session, and warm welcome to all from India.
Hello. Hi. Hi. Thank you for the very kind introduction. And I thank Professor Kato and Matron Shing for the invitation and for the opportunity. I think we'll go ahead with the session. Can we go ahead with the session? Can I share my content?
Yes, please, Prof.
Is my screen visible?
Yes.
Yes, yes.
Yes,
Okay.
visible. Thank you.
So yeah, so we'll just my topic of interest is today's discussion is also spinal cord injury. We see a lot of spinal cord injury in this region, especially in the eastern part of India, and we are one of the major referral centers for most of these spine related issues, including traumatic spinal cord injury. And what I'm going to go through is about what are the current guidelines that are available in management of spinal cord injury, especially from the major role that nursing from the nursing perspective. So what will be the basic learning outcomes will be the assessment, treatment, and what further decisions that can be given on about the spinal cord injury. As I've already told, spinal cord injury is a very highly morbid and very common health problem, and it usually is seen in a more younger population, which is a working population, and economically the nation depends upon this young working population for the economic growth and drive. And getting inflicted by spinal cord injury and becoming disabled is one of the it affects the person individually as well as the community and family of the person. So why do we need a specific guideline for this? So it is very clear that you can see the graph here. The graph in the first is before the introduction of guideline, and then the after the introduction of all these guidelines, you can see the amount of reduction. There is almost up to 50% drop in both the morbidity and mortality and case fatality rate when you follow a specific set protocol in managing any pathology, especially in trauma. When if you and the whole idea of setting a guideline is it introduces a uniformity in practice, and with the uniformity in practice, there is a uniformity in data collection, and once we go back and assess the data, we will be able to implement audit, implement, and introduce improvements in whatever service that we are providing. Hence, it is a well-known fact that guidelines are important. So how do you get to these guidelines? We all know that guidelines are formed from evidence that is available in literature, and this is how you generally grade your evidences. The topmost part, it will be systematic reviews, and followed by randomized control trials, followed by systematic reviews on cohort studies, and then individual cohort studies, then outcome research, then individual case reports, case studies, and case series. So as you go down the evidence, as you go down the evidence pyramid, the strength of evidence and the strength of the results also change. So this is the traditional evidence pyramid. The top of the pyramid, as we have seen, it starts with a systematic review and meta-analysis, followed by randomized control trial, cohort studies, case control studies, and case series. But we have to understand that this evidence is from a very limited population. It can be extrapolated to a whole population, but it has greater amount of variability when you apply the same thing to different population. This evidence generated in a European country, evidence generated in a North American or a Scandinavian country may not be directly applicable to a place like Asian population, where things are totally different. So that is where the current guideline model comes. So because these evidences have a large magnitude of an effect, dose response gradient will be there. There will be effect of plausible risk confounders. Multiple confounders will be there. This will all enhance the normal evidence, even a low quality evidence like a cohort study. With these things, it can enhance the evidence. And when there is a risk of bias, when it is inconsistent, and when there is a publication bias, even a top quality evidence like an RCT, it may not be applicable generally to the general population. So this is the problem when we follow a traditional pyramid and if we base our practice on a traditional evidence-based pyramid, and that is when you get to a current model where you use this evidences and see what is more and what is less, and propose a guideline after analyzing all the evidence. So that gives, and the guidelines can be different from different places. Like Bhubaneswar can have a different guideline. Same thing in Malaysia and Japan can have a very different guideline based on their interpretation of the evidence in their setting, in our setting. So it's something like this. So I mean, yeah, you have evidence. That does not mean you should use the evidence when you can actually find somebody who can guide you to cross a mountain in a very easier way. It does not mean that there is a mountain you always should use a rope and climb like that. There will always be somebody who knows better, and that is where a guideline, the interpretation of evidence based on experience and guidelines will help in our practice. So let me just start with a small case scenario. We have a 45-year-old person who had a fall at construction site. Very common in many of the areas around here. Construction site and fall. Initially, he was conscious, and slowly over a period of 15 minutes, he deteriorated, became unconscious. So what will be the first response? If you are the first responder, if you are at scene, and if you are the first responder, what should I do next? So you routine things. You check for oxygenation and blood pressure. Look for airway. Just make sure that the SpO2 is less than SpO2. Just make sure that the SpO2 is more than 90 and systolic blood pressure is more than 90 millimeter of mercury. In all patients with a head injury or a spinal cord injury, high flow oxygen should be administered immediately, and you have to see whether the patient has any signs of airway compromise. So how do you check? First, you talk to the patient. If there is clear, if he is able to answer back properly, then the airway is secure. If he is not able to do that, maybe give a jaw thrust, look for any foreign body, perform oral suction, insert a oral airway, clear the airway, and see whether the breathing is noisy or not. And then decide about going for a definitive airway, or if you don't have any facility for a definitive airway, go for a semi-prone position. Same way, you assess for breathing, see whether the breathing is spontaneous if the patient is not on ventilator. And if the patient is on ventilator, look for auscultate, look for the clinical chest movement, and look for the other ventilatory parameters, pulse oximetry, end tidal volume, arterial blood gas. And if the patient is not, if there is spontaneous breathing, look for any accessory muscle use, like use of neck muscle, use of muscles of the chest, thorax, and look for any abdominal breathing. And all these will give us a clear idea about how exactly is the breathing. And then, depending on how the breathing is, how the airway is, go for intervention, either through a oral airway, or if he needs an intubation, go for the intubation. Then look for blood pressure. So what are the signs that we routinely use for assessing blood pressure is you look for tachycardia and look for poor volume status by pulse. If next thing is look for a capillary refill in your peripheral limbs. You see if the capillary refill is more than 2 seconds, if the limbs are cold, and if the if the pulse is very thready and rapid, then mostly the blood pressure is low. So there is one thing in spinal cord injury where neurogenic shock, where you will have a low blood pressure, but there is no compensatory response where you have a tachycardia. The pulse will be normal, but still the blood pressure will be still low. That is a condition called neurogenic shock, which happens in thoracic spinal cord injury above D6 level. And when this happens, this will be a tricky situation where you will not be able to pick up the shock just based on your blood pressure, and this might require more intensive management of hemodynamic status. Yes. So because most of these spinal cord injuries are also associated with head injury, so routinely once you start with your airway, breathing and circulation, next thing that we go is assess the general status. We look for the Glasgow. The routine way that we use assess for the coma status is the Glasgow coma score. So how do you go? You first check, and then you go in a stepwise sequence. Check, observe, stimulate, and then rate. COSR. So that is how you go ahead with assessment of a Glasgow coma score. So what do you check? Check for whether the patient has whether he is there anything else that is interfering with his communication, whether he is able to respond, whether he has any oral injury, facial injury that is affecting our assessment of a Glasgow coma scale. If nothing is there, then observe, see whether the patient is opening eyes spontaneously, whether the content of the speech and his movement of his limbs are equal, and then if he is not having any of this spontaneous response, then you go for a stimulation. The stimulation is first you give us call the patient's name and try to wake him up, respond for ask for a response. And if that does not happen, then you can give a pressure. Pressure is usually given at the fingertips or in the trapezius or at the supraorbital notch. The pressure that is given in the chest is no more routinely followed, and it should not be given. Whenever pressure is being applied, try it in the fingertips, supraorbital notch, and the trapezius. And then you go and rate for your Glasgow coma score. This I'm not going to go in much detail about this. This I think is everyone will be knowing. It's E4, V5, and M6. So eye opening, verbal response, and motor response. You score the Glasgow coma score and look for what exactly is the response. So your airway, breathing, circulation, and neurological response is assessed. Along with that, you look for any pupillary asymmetry, to look for any head injury. So I will skip this part. So a patient is assessed in a pre-hospital setup, like at the site of injury, like in our case at a construction site. So first thing, what you will do, he is unconscious. You don't know whether the patient has any spinal injury or not. First thing is and then the history. There is a history. The fall is there is a history of significant fall. So first thing you have to do is go for spinal immobilization. Spinal immobilization is recommended. It's for all patients with severe spinal with a mechanism of injury that have a potential to cause a spinal cord issue. So how we do it is you triage the patients, see based on history, based on the fall, like patient with a history of fall from a significant height, patient who is ejected from a car seat, patient who was in a two-wheeler pillion rider and had fallen down at a significantly high speed, old people who had a fall, trip and fall, patients who are under influence of alcohol or drugs and who are not in a very clear mental status. All these patients are considered high risk, and these patients, and if there is by history, if these are the things that you notice, go for a spinal immobilization. Immobilization for an awake, alert patient who is not intoxicated, without any neck pain or tenderness, who do not have any abnormal motor or sensory findings, and who do not have any significant associated injury, should not undergo any kind of immobilization. It is not recommended according to guidelines. And we have a level 2 guideline, level 2 recommendation for this guideline. So what are a combination of a rigid collar or a supportive block with backboard with strap is effective in limiting the motion of the cervical spine, and it is very, very much recommended. The long-standing practice of attempted spinal immobilization with a sandbag and a tape it's not sufficient, and it is not recommended. But if that is the only thing that we have, I don't think there should not be that should not be an issue. You have to try some modality to immobilize the spine. And spinal immobilization is penetrating trauma. Patient with a penetrating trauma, like for example, something probably a knife sticking in or a rod sticking in, especially in a construction site. Patient with a penetrating trauma, if spinal immobilization is not recommended because of increased mortality from delayed resuscitation. So this is one thing that we have to take home. Transportation is always, it is advisable to transport to a nearby center, acute spinal cord injury center, which is the most nearest accessible center. Immediate transportation is required. And how do you assess them? So how do you assess neurologically? Is there any objective way? Like for example, for head injury, you have a Glasgow Coma score. So same way for spinal cord injury, there is an American Spine Injury Association score, which is basically a very detailed score. I'll just show you that. So this is an American Spinal Asia scoring. I think many of you must be knowing about it. It has a motor component, it has sensory component, and it has multiple points for both right and left. And based on you just have to tick which all levels, what all points there is a deficit. And based on this thing, you can based on this Asia scoring, you can classify the spinal cord injury as a complete spinal cord injury, which will be Asia A. And depending upon the amount of motor and sensory involvement, the grading can go up. And complete injury is Asia A. Incomplete injury, where there is no motor but there is some sensory preservation, which is Asia B. Again, in Asia C and D is also incomplete, whereas in Asia C, the more than 50% of muscle group is has a power less than 2/5, and in D, more than 50% of muscle has a power grade more than 3/5, and E is normal without any spinal cord injury. So this is a way that, same like a Glasgow Coma score, you use an Asia classification to score the spinal cord injury. The other way of assessing the outcome. So this is acute setting, you use a Asia score. In a chronic setting, like when you're following up a spinal cord injury patient in your clinic, in your OPD, we have this functional outcome assessment score, which assesses the patient's feeding, bathing, dressing, other routine activities, and this can be compared at admission, at reassessment, and at discharge. So it is a 20-point score. And this score, if we employ it routinely in our practice, this can be a comparable score, and it can be used on a regular basis for our assessment also, for the patient assessment also, and data collection also. So these are the two scores that are recommended for documenting the the extent of neurological injury. So the pain, how do you assess the pain? So one is you will have a neurological deficit. The next thing a spinal cord injury patient will have is pain. So to assess pain, we have this basic spinal cord injury basic pain data set. I'll just are you able to see this small data set? So this one has the data collected for the last 7 days in a week. How much the pain has affected the day-to-day activities, how much it has affected your sleep and your mood, your overall mood also, and what kind of problems and where exactly is your pain. All these things can be documented, and based on the this is the standard scoring, or this is an objective way of documenting pain post spinal cord injury. Sorry, am I with you? Am I? Hello?
Yes, sir. Yes, sir.
Yes, Prof.
Yeah.
Sorry, I'm not able to see everyone. So in case if I get disconnected, please let me know.
Sure.
Yes, sure, Prof.
Yes. And feel free to interrupt and ask any questions at any point. If any clarifications are required, just stop me, and I'm happy to clarify with whatever I can clarify. Yes, anything? Hello? Okay, can I continue?
No. Please continue, please.
Yeah,
Go ahead. Thank you.
So so till this point we have first seen what is the first few steps. We'll have to assess the airway, breathing, circulation, and look for the neurological basic neurological status using a Glasgow Coma score, and assess the extent of injury using ASIA score. Assess the pain using the basic pain set that is recommended by the Spinal Cord Injury Association guidelines, and then the functional outcome based on the objective assessment model provided. So these are the things that we routinely use in our practice. Next, the patient has landed in your emergency room. How do you decide whether the patient will require an imaging or not? So we have this Nexus criteria, which is a National Emergency X-ray Utilization Study. We'll have to see for see for these following 5 points. See if the patient has any midline cervical spine tenderness, if there is any evidence of intoxication, if the patient is comatose, drowsy, dull, delirious, look for that. Look for any neurological deficit, and look for the mechanism of injury, whether it is a painful distracting injury. If none of these are there, then there is no requirement for a radiology, no requirement for any further imaging. You can just observe and then probably discharge the patient based on just this. If any of at least one of this is there, then you go for a imaging, further evaluation. So the easy way to remember this is with the mnemonic Nexus. N for neurological deficit, E for ETOH, which is alcohol intoxication, X for extreme distracting injury, U for unable to provide a clear history because of altered mental status, and S for spinal tenderness. So it's very easy to remember this. You can apply it in your practice in your wherever whenever you see the patient, receive the patient. This will be a quick way to assess whether the patient can be further needs further evaluation, or can be. It's easy to triage the patients with this criteria. If anyone requiring further investigation, maybe we should go to a little bit more in a more high observation area, and then others can be kept in a green zone. So what kind of radiological evaluation is required? All patients will require a 3D CT and three view X-rays. The X-rays are an AP X-ray, lateral X-ray, and open mouth odontoid view X-ray. A patient who are awake and asymptomatic without any pain does not require any X-ray evaluation, as we have already seen, and we can discontinue the cervical mobilization. Patients who are symptomatic, you get this CT imaging. If the CT imaging is not available, then till then you can continue with the can go for an X-ray and continue with the cervical immobilization. And if the CT is normal in a patient who is awake but still symptomatic, continue with immobilization till he becomes asymptomatic. And after that, you can discontinue the immobilization after getting a dynamic X-ray, which is a flexion extension X-ray, and discontinue the immobilization based on MRI imaging for 48 hours. Whenever a patient is confused or not evaluable or uptended patient, you get a CT and wait for the patient to come out of the become normal, like become totally conscious, and then probably assess him for pain and neurological deficit. Till that point, these kind of patients needs to be continued on a collar, and removing collar depends upon imaging finding and the decision of the physician, and depending upon the neurological status of the patient. The one more thing that we routinely do in a patient with spinal cord injury in emergency setting is doing cervical reduction, closed reduction of facet fracture. This can be done bedside, and usually pre-reduction MRI is not required for a awake alert patient. That is what the recommendation says. The recommendation does not recommend MRI in a patient who is awake and alert and whose neurology can be assessed. Only pre-reduction MRI is required only for a patient who is comatose and who is in an altered mental state before a reduction. The cardiopulmonary resuscitation of these patients, the recommended mean arterial pressure to be maintained for the first 7 days is around 85 to 90. And systolic BP should be made sure the systolic blood pressure does not go below 90. The mean arterial pressure for the first 7 days, it is recommended is between 85 and 90, using whatever inotropes that we routinely use. Methylprednisolone was quite commonly used, quite controversial, but there is a recommendation is not does not support use of a methylprednisolone or any kind of steroids. Usually, spinal cord injury patient has a concomitant head injury, and there is a crash trial, which clearly says steroids are deleterious for head injury. So that with that logic, maybe it should not be again. Maybe even if there are studies that support use of steroids in spinal cord injury, it is a conflicting evidence between spinal cord injury and head injury, and I personally think that it should not be used in a routine way, and recommendations also say that does not support this practice. So I will skip the details about individual fractures, and let me just sorry, I'm just so yeah. So next thing is how do you for a cervical spine injury or a thoracic or a thoracolumbar spinal cord injury, we use this subaxial cervical spine injury classification, same way thoracolumbar injury classification. What is this classification? It usually uses the injury morphology. It is either called as a slick score or a T-lick score based on which part of the spine that is injured. But if it is subaxial spine that is involved, you use a slick score. If it is a thoracic and lumbar spine, you use a T-lick score. So how does this score work? It takes the injury morphology based on imaging, CT radiography imaging, and it takes the integrity of the discoligamentous complex based on MRI and the neurological status of the patient. So all these things, three things are taken, and there is a score given for each of the components, the extent of injury for each of the component. Anything less than 4 is managed medically, conservatively. Anything more than 4 is managed surgically, usually. And some in between 4 is basically it is managed either ways, depending upon the morphology and what the physician feels. So this is one very commonly used terminology in spinal cord injury, and probably we should be knowing that, because the other classifications, the older classifications called these Harris classification, Allen's classification, these are all not recommended because there is significant difference in inter-rater reliability. Me doing and somebody else doing, or even me myself doing it after a specific period of time, I may not be rating it in the same way compared to the slick or a T-lick scoring. So this is one thing that we have to know. Then the other thing is about traumatic central cord syndrome. In traumatic central cord syndrome, the early surgery is recommended. We have a very recent trial, STASIX trial, which clearly recommends early surgery within the first 24 to 48 hours to stabilize. And patients who do undergo early stabilization have a better outcome. So acute traumatic spinal cord injury, immobilize the patient, and early reduction and fixation is recommended. Surgical decompression is recommended. One special, we are coming towards the end of our talk, where we'll discuss about pediatric spinal cord injury. See, it is same like adult spinal cord injury, but CT, there is level 1 evidence that CT is the most common diagnostic modality that is used, where you see the condyle C1 interval for pediatric patients who has the potential to have this atlanto-occipital dislocation. So the CT is the most recommended imaging modality. Again, like in adult, like in Nexus, if the child is more than 3, alert, no neurological deficit, without any tenderness, without any distracting injury, without any unexplained hypotension, no need to go for a imaging evaluation. And the most common imaging evaluation is the CT that is being used. One important and very common thing that we see in pediatric patients is the spinal cord injury without radiographic abnormality, sciura. This is very common in pediatric age group, and there are many implications for this, because we don't know whether how exactly to go ahead, whether they can get back to contact sports, whether they can go back to school. Children are by nature, they are active and would want to be more involved physically, whether we should allow or not allow. So what the recommendation says is, any patient with a spinal cord injury without any radiographic abnormality, the imaging modality of choice is MRI. MRI should screen the whole spinal column, and the assessment of spinal cord injury stability should be done using a flexion extension X-ray. And neither we don't routinely recommend angiography or a myelography in patients with sclera. The usual recommendation is immobilization with a collar for around 12 weeks. Early discontinuation if the patient becomes asymptomatic, if the child becomes asymptomatic, and the spinal stability is confirmed using a dynamic X-ray. And up to 6 months, there is a clear, the recommendation is to avoid any high-risk activity like contact sports, rugby, football, basketball, swimming, jumping, diving. All these high-risk activities are suggested to be avoided in children with sclera. There can be, very rarely, there can be association of vertebral artery injuries. Almost around 20 to 25% of cervical spinal cord injury can have vertebral artery injury. The signs of vertebral artery injury is you can have arterial hemorrhage from the neck, expanding hematoma in your neck. There can be focal neurological deficit, and more importantly, stroke. And the risk factors is high energy transfer mechanisms, displaced mid-face fracture, mandible fracture, complex skull fracture, subluxation involving the cervical subluxation involving the transverse foramen, a near hanging injury, traumatic brain injury, scalp degloving injury. All these mechanisms are high risk mechanisms for a vertebral artery injury. Conventional angiography is recommended. MRI is recommended for diagnosis after blunt cervical trauma in patients with complete cervical spinal cord injury. It is recommended that the choice of therapy for vertebral artery injury is anticoagulation versus antiplatelet versus no treatment. But it is based on the individual patient. All these options are available. The options can be chosen based on the case by case scenario. And there is a role of endovascular treatment also if there is complete transection, if there is continuous hemorrhage, and if the patient develops any stroke. Last two things is, one is deep venous thrombosis and thromboembolism is very common in patients with spinal cord injury who is completely paralyzed. Prophylactic treatment is highly recommended for these patients, and usually we start the prophylaxis if at all there is surgical intervention is required within 48 hours of surgical intervention. If the neurology status is same and if peripheral other injuries are ruled out, patient can be immediately started on either low molecular weight heparin or a combination of modalities as a prophylactic measure to avoid the development of DVT and thromboembolism. Oral anticoagulation alone is not recommended, and early administration of thromboprophylaxis, as we said, within 48 to 72 hours is recommended. A 3-month duration of prophylactic treatment for DVT and pulmonary embolism is recommended. Vena cava filters are not routinely recommended as a prophylactic measure, but is recommended in patients who have failed anticoagulation and who are not candidates of anticoagulation or mechanical devices. The routine method of diagnosis is, as we all know, it is a duplex Doppler ultrasound most commonly used. And the nutritional support, we have a level 2 evidence suggesting indirect calorimetry as the best means to determine the caloric needs of spinal cord injury. And nutritional support should be started within the first 72 hours, as soon as it is safe, because the nutritional status has a direct impact on the overall outcome of the spinal cord injury patients. So with these are the recommendations that are current recommendations that are routinely used for spinal cord injury patients. And I think I have covered almost everything that is needed to be discussed. If anything specific that I think I have missed out, I think please, or if there are any specific doubts, please let me know, and I can discuss about that.
Yeah, thank you, Dr. Arunkumar, Dr. Arun Sekar. So it was a very comprehensive talk, specifically oriented towards the spinal cord injury. I could very much relate because I worked in Indian Spinal Injury Center. So with the talk and the latest guidelines are very true. And just I have one specific question. You have you have expertise in NIMHANS as well. Yeah, and now you are in AIMS. So how would you relate the management? Is it more or less the similar according to the guidelines, or is there anything extra which is done in NIMHANS? Because it is a center for neuro rehabilitation as well, not
Yes, yes,
just yeah. Because
yeah.
I have been there, and it is a yeah. So could you elaborate on that?
So one thing I feel that is difficult in this part of the country is we have very good facilities to treat primary treatment. We are able to give. I mean, because of the support from the government and because of the schemes that we are able to treat the patients primarily. But the recovery part, the rehabilitation part, is a bit lacking. Is what I feel. Even in our center, even we there are centers, but I don't think there are that many centers which can cater to the volume. The volumes are high. Not everybody is able to get access to the ideal treatment. But still, I mean, I don't see any major difference between the two places. It's all the standard of care is same everywhere. Only thing is the rehabilitation bit is a bit lagging behind here because of lack of resources rather than it's not because of anything else, just because of lack of resources.
Exactly. The reason why I asked this question is because the volume of people is more and the bed strength is limited, right?
Limited.
So, yeah, so every bed has a limit that the patient can stay on it, right?
Correct.
And then
Correct.
they have to go for the rehabilitation and the other management, because ultimately the patient has to reach back to the pre-disease condition. That is what, as a physician and as a nurse, we would want as a healthcare
Exactly.
part. Yeah.
Exactly.
So
And nursing intervention in early stages. I mean, usually when you triage a patient in emergency, who will need an X-ray, who will not need an X-ray, who will need further surgical intervention. All these, and then later stages after the surgery, in the later stages in rehabilitation stage, especially for pain management, a patient who is developing spasticity after spinal cord injury, bed sore, DVT, nutrition. All these have a very significant role for nurses to directly get involved, and it actually makes a huge difference. These things actually make a huge difference rather than because as if there is very little you can do once spinal cord injury happens. You can just go fix the spinal cord injury, but then the recovery, all these small things matter a lot.
exactly. Uh, if the if can I just share my experience as well?
Yes, definitely.
Yeah, because I worked in Indian Spinal Injury Center and I was there for 2 years. It is in Delhi. So I had one patient, I had many patients like that who were with me for the entire stretch, almost 1.5 years of my clinical experience there. I had patients with me, the same patient. So spinal cord injury is not that regular injury, just like head injury, spinal cord injury is a long-term condition, and that is why we all have gathered here to share our expertise. But this emotion, it has a drastic effect on psychological aspect, not just on physical aspect. That is what I feel. Yeah, please, if others want to share something.
Can we get the commentators, both Professor Lin and Professor Byron, to give us some comments or suggestions?
Well, thank you. Thank you very much. If I may speak, I would like to thank Professor Kato and Ms. Yi for this kind invitation to this academic event. So congratulations to Professor Sekar for this excellent lecture. And maybe I would like to make some remarks about a well-known controversial topic. As we know, when we talk about the progress and controversies concerning the steroid therapy for acute spinal cord injury, we need to understand that there are some landmark papers. As we know, the NACES one compared the effects of a low dose and high doses of methylprednisolone within 48 hours of the acute trauma. And at the end, we know that there was no difference in the improvement of neurological function regarding motor and sensory evaluations after 12 months and their follow-up. And the patients receiving high doses of methylprednisolone were more likely to develop complications, as you told, such as infection, death. And then later with the NICES-2 was the first clinical study to kind of demonstrate the effects of methylprednisolone after this acute CSCI, where motor and sensory recovery significantly appeared to improve within these 8 hours mark in patients with complete or incomplete lesions. But once again, gastrointestinal bleeding, wound infections were the common complications, and the NACES-3 was compared for different durations of this corticoid, methylprednisolone, within these 8 hours after the acute spinal trauma. So patients receiving this 48-hour treatment had greater improvements in their neurological status at 6 months, but this group presented high rates of wound infection, severe pneumonia, and sepsis. So I think as a conclusion, there is, as you said, limited evidence that steroid treatment improves neurological outcomes in this kind of patients with acute spinal trauma. And most currently guidelines, as you said, do not support its use because of their systemic effects. But I kind of wonder, what is the alternative to offer the patients an early surgery? And for this reason, a questionnaire, for example, was sent to Latin American countries and to spine surgeons, and the results show that there was a tendency to operate earlier, meaning before 24 hours of trauma, on patients with Caudequina syndrome and incomplete spinal trauma, as opposed to complete lesions or traumatic central cord syndrome. So the most reported obstacles that was said in this study was for an early surgery were the access to surgical implants and especially the delay of transport to reference hospitals for the surgery. So I guess for us, it's still difficult to decide what's best for the patients regarding each individual institution, their resources, and of course the prognosis of this pathology. So as we know, there are potential treatments like induced pluripotent cells, mesenchymal cells, Schwann cells, olfactory group cells, macrophages that have shown promising results. But for example, this kind of treatment is not available in our countries. So at the end, we need to choose. And there are some policies which I might concur that if, for example, that patient that I know that I can decompress him before 8 hours from trauma, I won't use steroids, I would do surgery. But if for any reason this is not possible, maybe I would initiate with the NACES-2 protocol and try to operate as soon as possible. We all know that after 8 hours, from trauma, it's not indicated any kind of steroids. And of course, we can never forget for these kind of patients that are polytraumatized patients, they will need the support and experience of the nursing team, the rehabilitation team to work in their improvement. So I would like to know in the experience of Professor or Sekar, if they have any experience with these treatments like pluripotent cells, mesenchymal cells, Schwann cells, something of this kind in your institution. Thank you.
Hello. Yeah. So we don't have access to any of these new modalities. And as you said, we are very limited in what we can actually do for a spinal cord injury patient when it comes to, we can just operate them as early as possible. And then what I feel is what I have seen in this thing is we have a group of patients whom we have studied over the last few years, our individual study. Patients who have undergone early surgery and have undergone early mobilization and early rehabilitation do have a significant amount of overall improvement over a period of 3 to 4 years. Other than that, our hands are also tied, and we don't have much to do for these patients. So what I feel is, if you surgically stabilize the patient, maybe they are, rather than external immobilization and everything else, once you surgically stabilize the patient and get him out of the ventilator, get him out on a wheelchair, get him to a rehabilitation as early as possible, everything else is kind of taken care of. So I think we should aim to all the policies, the policy, even the individual national level policies also should aim for a quick, like how for stroke, how time is important, first 6 hours, first 4 hours. Same way, we have to generate a policy kind of thing to intervene in spinal cord injury patients. And as I said, spinal cord injury happens in a more younger age group compared to stroke, cardiovascular issues, and more productive age group. So if you can, that small amount of time difference in time will go a long way, is what I feel. And other than that, steroids and everything else, there are, it is patient to patient basis. There is no control on what we can. We can just give and then expect for something good. So yeah, that's my take on. I think early surgery, early rehabilitation. That is the best we can actually give in our setting. Of course, other things has to be explored. Other things still can be explored and has to be explored.
Thank you, Professor.
Thank you. Prof. Lin, you want to say something just now?
Yes, thank you so much for that, Dr. Sekar, for that very comprehensive discussion on the guidelines. And also, I've been listening to the feedback. Yeah, I definitely agree. Early surgery, especially if you have already found out that there's instability, and also the time that one has to rehabilitate the patient is also of another value. The earlier that we send these patients home from the hospital, much better for these patients. Because in my experience here in our institution, we do at least every week we have a vehicular accidents, and just today we had 2 spinal cord injury surgeries with stabilization. Even complete cord with instability, we stabilize as soon as possible so that we can send them home. We can be able to make them sit up or high back rest in the bed and start rehabilitation. But again, another point is that I identified 3 stages in spinal cord injury. The first stage is, of course, the pre-hospital, which is the acute phase, the time from the injury to the time that the patient is brought to the emergency room is very important, especially in preventing secondary injuries for these patients or completing an incomplete cord injury. Then stage 2 is already the ER and the critical care, establishing whether the patient has spinal shock or not, and be able to pull that patient out of spinal shock. That's one thing. And here now, we have the role of not just a neurosurgeon, but especially the whole team. Especially if you are instituting ABC for polytrauma patients, because especially patients who may already have complete cord injuries may be missed with blunt chest or blunt abdominal injury. So this can be the cause of the death of the patient if this is missed. And then during this time, in our institution, we are able to operate. But then again, the common cause of death, if we prolong this patient's stay in the hospital, is again infection, especially pulmonary infection and also sometimes pulmonary embolism. And stage 3 is, of course, the chronic care of this patient, in which case patients go into depression. So I usually have these patients on antidepressants and psychological. I think it was mentioned also that this is not just physical, but there is emotional devastation in these patients who undergo these kinds of injury. So this is not just the patient's problem, but also the whole family's problem. So very important rehabilitation. When I tell them, that the rehab therapist will not come to you every day, it should be the support of the family who will exercise the limbs of this patient daily, especially the complete cord patients. And they should not leave the patients just lying down on the bed, So these are my comments. Thank you so much.
Thank you, Prof. Lin. Sister Sylvia, you want to say something? Unmute yourself, please.
Okay. I would like to thank the presenter for such a wonderful presentation and all the commenters for the great comment. But I would like to suggest that we put more emphasis on the rehabilitation, as the last speaker said, because most of the traumatic spinal cord injury patients from low and middle income countries, they reported the facilities in delay stage due to infrastructure and the financial constraints of the families. So sometimes they reach the hospital a week post-injury with cord edema, and which is really burden for the nurses in taking care of them. In Tanzania, we have a lot of such kind of patients, but they report the facilities in late stage. Very few of them, they normally came on time, like 24 hours, some hours after surgery, after accident, but most of them, they are from the far up countries where the infrastructure is also a burden. So it's better to insist on community education regarding the management at the scene so that they might save and prevent secondary injury. That's my comment.
Thank you, sister. Yeah, spinal cord injury is a problem for many countries, and it is usually we have to work as a team with the surgeons, the doctors, and all the therapists to rehab this patient. So in order to improve and for a better outcome, a good team is very crucial so that the patient will have a better outcome. So with that, I think we move on to the second session, the nursing session, will be chaired by Sister Sylvia, please.
Thank you. Thank you.
Sister Sylvia, can you please unmute yourself?
Yes, I would like to introduce Sister Grace Kombe, an experienced registered nurse from Tanzania. She's really having a great experience in caring for the spinal cord injury.
Just a minute, please. I'm sharing my screen.
Yes.
Is everybody able to
Yeah.
see my screen?
Yes, yes,
Yes,
yes.
yes.
Okay, good evening, ladies and gentlemen. My name, as Sister Sylvia said, I'm Grace Emmanuel Kombe, a registered nurse, but also a critical care nurse from High Dependency Unit in Muhimbili Orthopedic Institute. I will go straight to my introduction. Spinal cord injury is a serious medical condition which often results in severe mobility and permanent disability. It occurs when the axons of nerves running through the spinal cord are disrupted, leading to loss of motor and sensory function below the level of injury. And the incidence is that more than 8% of the injured patients are male, of which they are of young age, then they are breadwinners. And nursing care nursing care plan should collaborate with the personnel at the place where the patient was injured, doctors, nurses, and patient's family. Other injuries associated with the spinal trauma are brain injuries, chest trauma, abdomen or visceral injury, and the limbs and limb fractures. And here are the causes. Most of the causes of the traumatic spinal cord injuries are road traffic accidents, as the former speaker said, bullet or stab wound, traumatic injury, electric shock, extreme twisting of mid of the body, landing on the head during a sport injury, or falling from a great height. Now, the nursing care plans and management priorities are as follows. You have to promote effective breathing. As a nurse, you have to make sure the ABCs are well maintained. The ABCs are airway, breathing, and circulation, are well maintained by positioning the patient well. If need, the patient should be ventilated, or else you might provide deep breathing exercises, observe hypoventilations which lead to accumulation of secretions, observe skin color for cyanosis, observe abdominal distension and muscle spasms. Also, we have to encourage our patients to take plenty of fluids, like 2 liters per day at least, and also to measure the oxygen saturation and to administer oxygen whenever it is necessary. It is also advised we as nurses to do serial ABGs. We have the ABGs machines in our working settings, so it is good to check the blood gas for the patients. Another nursing management is to improve physical mobility. This, as we all know, spinal cord injury leads to impaired physical mobility due to the disruption of motor function sensation. Patient may experience muscle weakness, paralysis, or loss of sensation. So as a nurse, you are supposed to monitor all the body functions of this patient, upper and lower limbs, and to score them. Also, you have to measure BP half hour and to maintain the mean arterial pressure not less than 85 to 90 millimeters of mercury. Also, you have to change position 2 to 3 hourly, inspect skin daily by observing bed sores, and providing care by massaging areas which are prone to get bed sores. These are the sacrums, heels, occiput as the patient lies on his back for a long time, buttocks, hips, and the elbows. On the other one is, no, not this one, pain management and comfort. As we all know, spinal cord injury can cause acute pain due to trauma and tissue damage that occur during the injury. So as the nurse, you're supposed to make your patient comfortable and pain-free all the time. This is by administering analgesics, by doing physical therapy. The physiotherapist should visit the patient more often, apply heat or cold therapy, muscle relaxants, and anti-anxiety. And the other one is promoting effective urinary elimination. Spinal cord injury affects the muscles and sphincters of the bladder. So as a nurse, you have to make sure the patient is well rehydrated. As I said before, at least 2 liters per day. Observe urinary retention regularly. Maintain input and output record. Palpate bladder distension and overflow regularly. Assess color of the urine. This is you might find the urine has got blood, pus, or the smell. You have to check also, and advise doctors to do lab investigations like renal function tests, white blood cell count, creatinine, etc. The other thing is wound and skin care. We all know these patients normally get bed sores. So as a nurse, you're supposed to do assessment of the skin regularly, maintain repositioning of the patient 2 to 3 hours to relieve the pressure, proper hygiene to the patient, adequate nutrition, as the former speaker said, and the use of pressure relieving devices like air mattress. And also we have to do daily wound care. If the patient is having the bed sore or the post-operative wound, you have to clean the surgical site daily. The other intervention is to maintain bowel function. We all know these patients, they get constipation due to disruption of neural pathways that could control bowel function. So as a nurse, you are supposed to make sure this patient again is getting adequate fluid intake, is getting adequate fiber intake, proper positioning of this patient, and observe abdominal distension. The other point is recognizing, managing, and prevent autonomic dysflexia. We all know this is a life-threatening syndrome which involves the overreaction of the autonomic nervous system, and of which it can cause severe high blood pressure, it can cause a lot of complications. So as a nurse, you are supposed to watch signs, watch for hypertension, you have to watch bradycardia, you have to watch signs of infection, monitor temperature, and all of these should be recorded, documented. And also, you have to make sure the patient is on the monitor for close observation. And the last one is to enhance effective coping and self-care. This can be done daily by daily counseling to the patient as he or she may be on denial, depression, grief. So the patient is to be counseled every day. Also, this patient needs psychological support. There are a lot of things that he or she might be thinking on the sexual function, worries, and a lot of them. Who will take care of the family? So he needs psychological support. Also, we have to give education on how to, we have to give the education to the patient on how to adapt to live with the new circumstances. Also, we give education to the caregivers and the patient as well on prevention of secondary complications like bed sores when he has gone home, bed sores, upper respiratory tract infection, urinary tract infection, DVT, etc. And we have to do home visiting when the patient is discharged. But I know this is kind of difficult to some places. As to our place, we can't do home visiting due to the patient is coming far away from the hospital, limited funds and shortage of staff. But when they are discharged, we normally tell them to come after 2 weeks for a checkup. This is how we do the follow-up. So home visiting is a bit a challenge. And this is a conclusion. Injury to spinal cord doesn't mean end of life. Life can be still the same after the injury, but patients have to accept the changes. Rehabilitation play a big role to readjust in previous life. Spinal cord injury is not merely change the life of the patient, but family too. We as nurses, we have to play our vital role in nursing spinal cord injury patients. And thank you for your kind listening, and thank you for your time. Arigato gozaimasu. Thank you.
Thank you so much. So Sylvia? So Sister
Grace,
Sylvia?
and share your screen, please, Grace.
Okay.
Thank you.
Thank you.
Sister Sylvia, please continue. Where are you, sister?
Grace said it was a great lecture. Thank you very much. So the multidisciplinary team
Thank you so
support the patient is very, very important, especially spinal cord injury.
Thank you so much.
Home visiting is a good work as a nurse, I think. Thanks a lot. We learned a lot.
Where are
Thank
you?
you.
Sister Sylvia, where are you? Are you there?
Yes, I'm here.
Please
Yes.
continue.
Thank you so much, Sister Grace, for such a wonderful presentation.
Thank you.
And now I would like to save the nursing questions to the end of the 4 presentations. I would like to call upon Sister Irene. Sister Irene. I would like to call upon Sister Irene
Yes.
Swai. She's a young clinical nurse. Has a great experience in neurosurgical intensive care unit since 2017 up to date. She's committed in patient-centered care, and she don't talk much, but she is a self-directed in a holistic care once she's allocated patient. So I'd like to call Irene to give us her presentation regarding the case study for the spine cord injured patient. Sister Gracie, you are welcome. Sister Irene, you are welcome.
Hello.
Hello. Can you please share your screen and your presentation?
Yes.
Irene?
Yes. Can everybody see my screen?
Yes.
Yes.
Good evening, ladies and gentlemen. My name is Irene Swai, as Sister Sylvia introduced me. I'm working in the ICU Neurointensive Care Unit at Muhimbili Orthopedic Institute from Tanzania. I'm presenting about a case report on nursing management on traumatic spinal cord injury. We have outline presentation, patients demographic data, case presentation, outcome, and conclusion. We start with case. We have female, 32 years, nurse, single, with the file number EM 2024, date of admission 23 July 2023, ward admitted in ICU. On admission, patient was apparently well until 8 November 2023 at 4 p.m. Sustained injury to the spine. Admitted through emergency department as a referral from Loganzila Muhimbili National Hospital. She was involved in motor traffic crash as a pedestrian knocked down by a fast-moving truck. Chief complaint include weakness and loss of sensation in upper and lower limbs. Had no history of loss of consciousness, convulsion, no vomiting. However, had a fracture of the right thigh. Vital signs at present at the emergency department. Blood pressure was 123/89 millimeter per mercury. Pulse rate was 85 breaths per minute. Respiration was 24 breaths per minute. SpO2 saturation was 98%. Neurological GCS was eye open 4, verbal response 5, motor response 6. So this patient has 15 Glasgow Coma scale. Casualty specialist on call reviewed patient and requested radiologic investigation. Total spine X-ray, total spine MRI, chest X-ray, X-ray of the right femur and pelvis. On admission, laboratory investigation, complete blood count, blood grouping and cross-match, serum electrolyte, to apply Philadelphia neck collar, apply skin traction on the right leg for elective ORIF and intramedullary nail after spine stabilization. Then for neurosurgery team to review. Working diagnosis, polytrauma with the traumatic spinal cord injury, ASIA A, with cervical vertebra fracture, closed right femur fracture. Nursing neurosurgery team review the patient. Diagnosis, traumatic spinal cord injury, Asia A with the burst fracture of C7. Plan, emergency decompression and stabilization. Kept on IV ceftriaxone 1 gram OD for 7 days, IV paracetamol 1 gram TDS for 5 days, sub-Q Clexane 40 milligram OD for 7 days, IV fentanyl 100 microgram BD for 3 days, tabs Ligaba 75 milligram OD, NAT B 1 tab OD for 1 month to apply Philadelphia neck collar, then admit patient ICU. Patient received into ICU at 2 hours. GCS was 15, eye open, 4 verbal response, 5 motor response, 6, but quadriplegic. Vital sign, blood pressure was 97/48 millimeter per mercury, respiration rate was 25 breaths per minute, pulse rate 109 breaths per minute, SpO2 96%, temperature 36.4 centigrade. First blood glucose was 6.9 millimeter per liter. Plan to continue with the prescribed medication. Neuro observation, fluid input was 1,500 ml, output was 700 ml. Day 1, admission in ICU, saturation at room where central venous catheter in situ and urethral catheter in situ. Neurological, GCS was 15. Vital sign, 109 millimeter per mercury, respiration 25 breaths per minute, pulse rate 91, SpO2 93, temperature 36.2, first blood glucose was 8.6 millimole per liter, fluid chart is 4,100 mils, output 3,600 mils. On nursing management, day 1, neurological management, regular assessment of motor and sensory function below the level of spinal cord injury, monitor for signs of autonomic dysreflexia. Respiratory management, continue monitoring of respiratory status, given oxygen therapy 3 liters per minute via nasal prong. Implementation of deep breathing exercise and incentive spirometer. Positioning, intervention to optimize respiratory function. Mobility and position. Collaboration with physiotherapy for range of motion exercise to prevent contracture. Assisting with the position to prevent pressure ulcers. Encourage independence in mobile within the limitation of the injury. Bowel and bladder management. Implementation of a bowel and bladder management program. Regular catheterization and bowel programs. Monitor for urinary tract infection and complications. Pain management, regular pain assessment and interventions, pharmacological and non-pharmacological pain management strategies, development of a personalized pain management plan, psychosocial support, emotional support for the patient and family, addressing concern related to body image, self-esteem and lifestyle changes, facilitating access to counseling service. Education and rehabilitation, patient and caregiver education on the nature of traumatic spinal cord injury. Collaborate development of a rehabilitation and discharge plan. Encouraging participating in rehabilitation activities. Complication prevention. Implementation of measures to prevent complications such as deep vein thrombosis and respiratory infection. Patients and caregiver education on recognizing and addressing complication prompt. Orthopedic management, elective ORIF and intramedullary nail dunning, kept on IV ceftriaxone 1 gram OD for 7 days, IV paracetamol 1 gram TDS for 7 days, sub-Q Clexane 40 milligram OD for 7 days, continue with other treatment. Daily wound dressing, encourage high protein and vitamins diet. Outcome, improvement in respiratory function, prevention of pressure ulcer through delegation skin care, increase independence in mobility within the limitation of the quadriplegia, successful implementation of bowel and bladder management program, effective pain management leading to improved overall comfort. Patient discharge home after her condition has improved. Patient for follow-up clinic discussed with patient and relative. Continue to attend physiotherapy and physiotherapy clinic. Conclusion. The nursing care management of the patient with the traumatic spinal cord injury requires a holistic and interdisciplinary approach. Through ongoing assessment, intervention, and patient education, the nursing team plays a crucial role in optimizing patient outcome and enhancing the quality of life for individuals living with the traumatic spinal cord injury. Thank you for listening.
Okay. Thank you. Thank you so much, Sister Irene, for such a wonderful presentation.
Thank you.
That's great. Yeah, thank you so much. Can you close your screen, please?
Okay. Joseph.
Okay. Once again, thank you for the two nurses. Now I'd like to call the third nurse, Mai Okubu. She's a nurse practitioner in neurosurgery department at Fujita Health University Hospital. She has a great experience in acute care nursing as well as perioperative management nursing. Working with her as a staff nurse is a great. So, Mai, welcome to share with us your experience in working as in neurosurgery, as well as the experience of your fellowship. You're welcome, Mai.
Thank you. And I'm going to presentation with NP Okubo. So I'm going to do presentation first, okay? And I'm going to share my slide. I'm sorry. Maybe I couldn't share my PowerPoint. I'm sorry, I'm taking time.
Thank you.
Now I can share my PowerPoint.
We can see your screen now.
Thank you. I'm so sorry taking time. And thank you for the opportunity. And it's a great honor to be able to speak to you today. We went to Vietnam for attending the Vietnam Neurosurgery Society in Hanoi on December last year with MP Okubo. And today we would like to report what we learned through the Vietnam Neurosurgery Society. I'm going to do presentation about us and nurse practitioner system in Japan and Vietnam we researched before we went to Vietnam. And NP Okubo is going to report about the Vietnam Neurosurgery Society in Hanoi. And first of all, I am NP Okubo is from Japan, obviously, and I believe we are so close, like best friends, but we usually work different hospitals in Japan. Our commonality is that we are nurse practitioners in the neurosurgery field. And also, we both are growing as nurse practitioners in neurosurgery field through friendly competition and cooperation by Professor Kato. In Japan, nurse practitioners are counsel certified nurses who have received education in the medical paradigm at graduate school after more than 5 years of clinical experience. As for the way of working, we think it is easy to imagine that it is positioned between doctors and nurses. Future issues for nurse practitioners in Japan include recognition and qualification. That's why it's important for us to demonstrate the safety and usefulness of nurse practitioners. As a nurse practitioner in the neurosurgery department, we work in a wide variety of locations, including operations, outpatients, and ICU and wards. And we researched about Vietnam before we attended the Vietnam Neurosurgery Society in Hanoi. So we share the information in Vietnam. Vietnam has health insurance and the Vietnam government aims for universal health insurance, and the number of enrollees is increasing year by year. Degree on the details of the medical insurance system was enacted in 1992. The system consists of compulsory and voluntary medical insurance. Developed during the Vietnam War, response to first aid and emergency care nurses' role was limited to technical tasks such as administering, curing, and dressing wards and not medical aid. In recent years, the role of nurses has changed to the a total care provider who is responsible for the care of patients together with doctors. The Vietnam Nursing Association was established in the 1990s. There is no national examination system, and each provides recognition that completion of nursing education. Vietnam has already entered an aging society by 2019. Vietnam's total population will be 96.2 million with an aging rate of 7.7%. However, the total fertility rate has declined significantly from 3.55 in 1990 to 1.85 in 2016. Its aging rate is estimated to be 15 years faster than Japan and Cambodia. Stroke has been the leading cause of death in Vietnam over the past decade, according to statistics from the Vietnam's Ministry of Health. Approximately 200,000 people suffer from stroke each year, about half of whom die, and 90% suffer from the after effects. It is estimated that there will be 8 doctors and 14 nurses per 1,000 population in 2019, compared to the 14 doctors and 30 nurses at the Asia Pacific level. The shortage of nurses in Vietnam is quite serious. In addition, acute stroke rehabilitation is rarely provided in Vietnam. The most impressive thing about Vietnam was the amount of traffic. I was surprised that I was able to return to Japan without having a traffic accident. The traffic accident fatality rate in Vietnam is 10 or 11%, which has not changed since 1990. In 2018, there were about 80,700 traffic accidents. About 40% of rehabilitation patients are head injury patients, which in some hospitals is more than stroke patients. So we believe the biggest healthcare problem in Vietnam in the overwhelming lack of quality and quantity of care in nursing and rehabilitation. After researching this medical situation in Vietnam, we attend the Vietnam Neurosurgery Society. My specialty is endovascular and NPO specialty is craniotomy. So I talked about contribution of nurse practitioner to acute ischemic stroke treatment, and NPO talked about optimal steps for planning patients in the park bench position. In the Vietnam Neurosurgery Society in Hanoi, and from now on, NPO will report about what we learn in the Vietnam Neurosurgery Society.
Okay, next. 千野さん、次のスライドお願いします。Okay. We participated in the 22nd annual meeting of the Vietnam Neurosurgical Society held in December 2023. Next. And 次お願いします。In the nursing session, there were 25 presentations with the same nursing care for brain surgery. Its presentations share their facility daily achievement based on data. 前戻ってもらっていいですか? I felt that the desire to improve treatment and care in the field of neurosurgery is the same across countries. Commentator Eugene talked about how nurses must continue to think about good care, left a strong impression on me. Our presentation related to the Japanese NP system. We noticed that such systems are less prevalent in Asia compared to the West, and we aspire to expand our activities beyond borders. And next, ACNS, which was held jointly with VNS, held workshop and lecture over 2 days. In the hands-on seminar, many young Vietnamese doctors actually used drill and microscope to learn about cerebrovascular and skull-based neuroanatomy in detail. I was inspired by how serious and enthusiastic they were. On the second day of ACNS, many doctors, including Japanese doctors, next slide, please. Okay, gave lectures on cerebrovascular skull-base and neuro-oncology. There was also an award ceremony for doctors who gave outstanding presentation and nurses who cooperated with the conference. And we also attended gala dinner and conferences and interstate with many doctors and nurses. It was a very valuable experience for us to actually meet and talk with people that we would not have been able to meet if we hadn't attended this conference. So it was our first time visiting Vietnam, but we fell in love with there because all the staff were very kind and hardworking. We sincerely thank them for their warm hospitality. And Vietnam does not yet have an NP system, but we learned that they are interested in Japanese NP system because they are thinking of creating a more advanced nursing education system in the future. We were very inspired by the fact that many Vietnamese nurses are eager to study and go on to graduate school overseas. Although the systems and medical levels differ from country to country, we felt that each country is working together to develop the field of neurosurgery. We would like to continue contributing to the development of neurosurgery through participation in conferences like that. So thank you for your attention.
Sister Sylvia.
Sister Sylvia, can you continue? Are you there, sister?
So E, can you continue, please?
Christine, please take over, Christine.
Yes, okay, ma'am.
Christine, okay.
Yeah. Okay, thank you for your presentation. For the second session, we want to invite for the please Prof. Lin and Prof. Parent. Any suggest or the discussion for the session, please? Before,
Well,
yeah, please.
thank you very much, Ms. Christine. I have a question for the speakers. As you know, well, I like controversy, so I would like to ask you, what's your experience in in the management of the vesical dysfunction. We all know that in some services and some papers, there might be a low rate or infection when we use a intermittent vesical catheter catheterization, instead of just leaving the vesical catheter for a few days, maybe weeks. So I would like to know how you manage this, because sometimes when the patient goes home and goes well, with their relatives, they actually are not essentially doctors. They don't know how to take care of this catheterization. Sometimes money, it's a problem to hire a nursing that can go home and stay all day long, you know. And sometimes when we send with this vesical catheter for a long time, we know that they will get infected. Sometimes they don't take care. They don't take care of the bag. The bag sometimes can have holes in it, can get damaged. So I would like to know how you manage this problem.
Irene. Irene.
Thank you. At our hospital, we do like we tell them to come at the clinic. The date when they came to clinic, after 14 days, they're supposed to come to clinic. Then we remove with catheter and insert a new one.
In addition to what Irene said, as I said before, due to infrastructure, for those who are nearby hospitals, it's very easy to manage them and visit clinic after every 2 weeks. But for those who are far from the hospital, we normally advise them not to use catheter. Instead, they normally use diapers, and then the caregivers are strictly educated on how to manage those patients at home. We prefer to educate the adult caregivers who are really committed to take care of those patients while at home. But in some families, they normally hire a part-time nurses to take care of the patient at home. That's the system we normally work with in Tanzania. But most of them, as I said before, they normally reach to our institution very late stage with bed sores from the upcountry region. And then our task now is to reach the regional and referral hospitals in education on how to manage spine injury patient and neurological patient in general. And we normally invite the nurses from the peripheral centers to attend the course in our institution to empower them on how to reach and manage this before they came to our institution for nurses continuously at the training. Does it make sense to your question, Mr. Blaga? Any more contribution regarding the management of spine patients, please?
Ms. Sylvia, we have question from the chat from Ruth Mosi. Yeah, she is have 2 questions.
Hi. First of all, I like to congratulate all the speakers for that very extensive and comprehensive deliveries of lectures. And again, I would like to congratulate you also on your work as the part of the team, especially the nurses when you are working with the spinal cord injury patients. This can really be very difficult because not just we are dealing with the patient, but also we are dealing with how to educate the relatives, you know. educating the relatives is also very important, especially if you are making them ready to care. If they cannot afford a caregiver, then they have to be the ones to care for these patients. So yeah, especially if those patients, even just the complete cord, turning them to avoid complications like bed sores. It's very important. It's not just the sacral sore, but also the ankle, how to position them, and also if they cannot afford rehab, because here in our place, the therapist and the rehab doctor are not that many. So sometimes even me as a neurosurgeon and my nursing team have to remind the relatives to flex, to extend, to exercise how many times a day, every hour. I mean, very specific like that. Those things, because if they make the patient lie down in a certain position, then the knees will bend and then they will never be extended, and the patient will be in pain and cannot be put up on the bed. All those simple things. Sometimes, again, as you said, the infrastructure can be really a problem, especially in countries like of Philippines, where I am. It's resource poor, especially even in rehab doctors. So again, I would like to commend you for this very good session on spinal cord injury. Thank you so much.
Thank you.
Thank you.
Thank you.
Ms.Irene. You want to speak something, Grace? I
No.
welcome panelists for suggestion and contribution on the way forward on how we can move and save the life of our patient with less complication. Any contribution, more contribution? Okay. I would like to welcome Matroni Chen to take over and welcome Professor Kato to proceed with the session. Thank you. Matroni?
Yeah, thank you very much for the lectures and the commentators for the good advice and suggestions. I think we have a very good session and very informative section. Yeah, spinal cord injury is a problem in many countries in the Asian region. Likewise, in Malaysia, we too facing problem with rehabilitation for spinal cord patients. And the rehab ward in our hospital is only 10 bedded. And that is where our neurosurgical wards need to start the rehabilitation first before we send over to the rehab ward. So nurses actually, to nurse these type of patients, we are facing a lot of challenges. I'm sure likewise in any other countries in the Asian region. So anyway, nurses usually will work together with the surgeons, the therapists as a team to improve patient outcome. I think we have a very good session. Thank you very much. A call upon Professor Yoko Kato to say a few words before the closing.
Okay, thank you very much. So we learned a lot, especially the Lene and also the Byron. Their comment is very valuable. I think informative. So today that we especially the focus on the spinal cord injury. So this is one of the most difficult territory, I think. So the multidisciplinary team can I think support patients and also the treatment. So I think the matronee, thank you very much for your great organize of this session, and also the Seno-san and my son and your report. You visited Vietnam. You had a great experience. I think, to meet, to discuss with other countries, to know the situation of other countries. The nursing system is very, very important, I think. So thank you very much it was great, I think, that nursing webinar.
Okay, thank you very much. I think we will end the session. Thanks again for with us and for the support given to ACNN. So meet you all again. Thank you very much.
Thank you.
Bye.
Thank you. Thank you very
Bye.
much.
Thank you, Byron.
For the
Bye.
invitation.
Bye.
Bye.
Thank you, Prof.
Bye.